now move on to the first panel discussion of the day, to be moderated by Dr. Anupam Das, Assistant Professor of Dermatology at KPC Medical College, Kolkata. Request you to please kindly take the stage, sir, and introduce the panelists. Thank you.
A very good morning to all of you. Without further delay, I would like to invite my esteemed panelists on stage, please. Dr. Raghubir Banerjee, Dr. Gulati, Dr. Kiran Godse, Dr. Abhishek De, Dr. Indrashish Poddar, Dr. Bornali Dutta, and Dr. Ananth. Since morning we have listened to some fantastic lectures by Dr. Raghubir, Dr. Ram and Dr. Kiran Godse. Now at the outset I would like to thank Shondipan sir for this opportunity to moderate the panel, and sir has strictly told me that the panel has to be very basic. The panel has to give as many take-home points as possible. We are not going into, high funda pathogenesis, newer drugs, newer investigations. We will stick to basics, and we will try to create a bridge between the pediatrician's point of view and the dermatologist's point of view whenever we come across any case of dermatological problem in a child. So, Dr. Raghubir has discussed a lot about cleansers and moisturizers. Now, I'm sure our pediatrician colleagues must be coming across a lot of cases of atopic dermatitis. Now, atopic dermatitis, it's a pretty common condition. So, I'll not take the courage of speaking much on atopic dermatitis when Shondipan sir is there in the audience. So, whenever there is any recalcitrant dermatological condition, whenever there is a condition which is not responding to regular treatment, whenever there is extensive dryness, whenever there is family history of, say, atopy, allergic rhinitis, keratoconjunctivitis, dryness of skin, these are the situations whenever we are doubting atopic dermatitis. Now, what we have been taught from our medical school days that moisturizers are the most important, rather moisturizers are the backbone of any prescription of atopic dermatitis. We do prescribe topical steroids, we do prescribe topical calcineurin inhibitors, we do prescribe antihistamine, cyclosporine, oral steroids, so many things are there. But moisturizers is something which has to be there in almost each and every prescription of atopic dermatitis, be it a mild disease, be it a moderate disease, and be it a severe disease. I would like to start with Dr. Bornali, following the convention of ladies first. Like, if you can briefly tell us what is the role of moisturizers in atopic dermatitis, especially for our pediatrician colleagues.
A very good morning to everyone. I feel that in atopic dermatitis, since the fundamental problem is in the barrier function and patients usually have a very dry skin, so moisturizers play a very integral role because this dry skin will cause itching, and itching will again further aggravate the barrier dysfunction, leading to release of this proactive chemokines and all, and this will, a cascade of reactions will follow. So moisturizers play a very important role, and a moisturizer should be such that it has all the it should be like Sir Dr. Raghubir Banerjee sir has very rightly said, it should be a perfect blend of all the essential substances like humectants, occlusives, and also nowadays there are addition of so many other things like anti-inflammatories, probiotics, antioxidants and all. So I feel it's a very, very important, one of the first and foremost line of treatment for atopic dermatitis is how to apply moisturizers and the importance of moisturizers.
Thank you. Yeah, Kiran sir. Yeah.
In fact, somebody asked me what is the best moisturizer.
Yes.
It's very difficult to ask what is the best moisturizer, what is the best sunscreen. So answer is very simple. If your child loves to use that moisturizer 4 to 6 times a day without any smell and without anything, that is the best moisturizer. Which child you must ask him. If the child doesn't like smelly, sticky, this thing he doesn't. So it has to be what child likes, and that is his best moisturizer because that is what he's going to use it regularly. Otherwise, whatever fancy we give, if child doesn't like, he's not going to use it.
Yeah, Raghubir sir.
as Dr. Kiran Godse rightly pointed out, what the child likes. The other day, Shondipanda was enlightening me regarding this, that even if a little bit of perfume or something is there, making it more acceptable, I think that is a better way of doing it. No perfumes, no scents might not be very acceptable for the child in the long run. So a little bit of perfume may be making it more acceptable for the child. As Dr. Kiran Godse likely said, that the child will like to apply that. So that is what we are trying to focus on.
Agrees. Indrashish, you are working in a government hospital, so what is your best moisturizer? Like when we did our PG, we used to learn that coconut oil is the best moisturizer. You still follow that?
Yes, I think for starting and especially moisturizers are pretty expensive. So yes, coconut oil actually takes almost all of them. It's a poor man's moisturizer, and it's good actually. And we have, I think it was in the discussion also, the virgin coconut oil and the cold pressed coconut oils. And moisturizer, I think everybody has said what the child prefers. So what we can do is, in case of such price sensitive conditions, applying coconut oil one time and applying moisturizer in the night might be kind of a good solution.
Okay, so that will balance the science and commerce both. Yeah, Abhishek.
A couple of things I need to point out here. First of all, moisturizers.
Yes,
see, bulk of your atopic dermatitis patient is basically mild atopic dermatitis.
Yes.
For these patients, moisturizer alone can be a treatment. That's one important issue. Second important issue is moisturizer per se decrease the number of flare, per se reduce the amount of steroids required for this patient to be treated.
Exactly.
Not only that, even for the moderate to severe patient where you are contemplating giving systemic treatment, moisturizer reduces the amount of systemic treatment to be required, suppose in a year. So all these facilities, so the amount of drug these children to be taken in this life, that cumulative insult to the drug will be reduced if you adequately use moisturizer. It reduces number of flare. So in between the treatment, when the flare is gone, moisturizer is the only and key treatment so that the number of flares goes down. So that's how it should be an important institution. However, we have to also remember the compliance factor of the patient. So there are prescription emollient devices. I believe Raghubir briefly touched about this. We have this wonderful ceramide containing filaggrin degradation protein containing moisturizers. However, this can be pretty expensive for many of our patients. So if you give this high expensive moisturizer, at times the parents will not use it adequately and not use when the flare has gone. But we exactly don't want that. We want the patient should be continually use moisturizer. So we need to, I would say, think about the patients and their, pocket and their cost factors, everything put together, and choose an appropriate moisturizer for the patient and make our parents understand that the patient has to be needed use moisturizer adequately and continuously.
Thank you, Abhishek. We have one audience question. Sir, if you could just introduce yourself, your name and place where you're coming from.
I'm Dr. Ravindra from Bangalore.
Yes, sir.
I'm Dr. Ravindra from Bangalore. In South, most of our dermatologists are using sunflower oil. How is your opinion?
Sir is asking the role of sunflower oil as a moisturizer.
As a moisturizer.
Yeah, Dr. Raghubir.
Many
Yeah.
of the dermatologists are advising.
Okay. In South, many of the pediatricians as well as dermatologists are prescribing sunflower oil.
Sir
Preferring
correctly
rather.
mentioned that sunflower oil is a very good moisturizer. Especially it has a high content of linolenic acid, which has a barrier repair effect on the skin, which the olive oil does not have.
Yes.
So in place of olive oil, if you recommend sunflower oil, that is a much better moisturizer and helps in repairing the barrier in case of atopic dermatitis.
So I'll come to my pediatrician colleague who is there in the panel. Say you have 10 to 15 pharmas who come to you with different ingredients in moisturizers, X, Y, Z, A, B, C, permutation combination. So when you choose a moisturizer, what are the ingredients you look for?
Very good morning to all of you. In the moisturizer, we are looking predominantly for ceramide component, so that the occlusive effect will be better. But predominantly mothers will prefer moisturizer which has got more perfume. They'll always say moisturizer हमने मॉइस्चराइजर डाला है पर कुछ मालूम नहीं पड़ रहा है कि मॉइस्चराइजर डाला है बदन में एक्चुअली तो थोड़ा अच्छा परफ्यूम वाला मॉइस्चराइजर बोल दीजिए बट इन द मार्केटिंग strategy many are there with perfume but we should look more for ceramide component in the moisturizer.
Dr. Ram,
I think as Dr. Godse said that the best moisturizer is something that the child likes. That is very important. Now, child doesn't know ceramide, child doesn't know what is there. What they want is to put that thing on the skin 3-4 times a day if possible. The problem with ceramides is that it's an expensive moisturizer. So if you can bring down the rates, very good. And what we are using actually is phytoceramides. So they are not the actual ceramides that are human ceramides. So are they going to replace the human ceramides effectively as the normal ceramides? We really don't know. So we don't know the pharmacokinetics of ceramide when they sit on the skin and how they go inside. Yes, I think there are certain families where money is not an issue, regular moisturizers are not doing the trick. It might be worthwhile trying a ceramide-based moisturizer, but again, because of the expense, I think regularly a simple over-the-counter moisturizer which can act like an occlusant and a humectant kind of a combination of both usually works very well.
Okay. So to sum up this issue on moisturizers, we need to balance science and commerce, number one. Number two, if the patient cannot afford, coconut oil is definitely a very good choice. Of course, if the patients can afford, we can go for those high-end moisturizers, those containing ceramides. And yes, whether those ceramides can actually replace the skin barrier is a debatable issue. So we need to go by the patient's choice, that is by the child's choice, whether he will prefer using that moisturizer again and again or not. So also if we go to the evidence also, several studies have shown that emollients can reduce the frequency of dermatitis and also improve the skin integrity and in different babies. And also it has been already discussed that sunflower oil is always preferred over olive oil because sunflower oil has that inherent property of improving the skin barrier. Now this was partially discussed. I will come to Abhishek, how much and how many times. This is something very important which is repeatedly asked by our... before that, I'll have a chocolate question for the audience. This is only for the pediatrician colleagues. Commonest gene mutation which causes atopic dermatitis. This is a chocolate question for the pediatrician colleagues. No, Abhishek is absolutely not allowed. Yeah, anyone? Chocolate question, yes. Yeah.
I'm not saying, they're replying the answer. So actually, long arm of chromosome 1 is responsible for atopic dermatitis.
I wanted to know the name of the...
In the region 1 band 2.
I'm looking for another answer. Yes. I want to know the name of the gene.
Can I say? Filaggrin.
Filaggrin gene, yeah, filaggrin. Who answered? Yeah. So the chocolate goes to the gentleman. Claps, please. Yeah. So I come back to Abhishek. How much moisturizer and how many times a day?
See, basically it's recommended at least 2 times in a day. The more important is you have to use it adequately so that the entire body is covered. That's how it's written in Western textbook. I'll slightly differ what our experience is. Second thing, in case of adult, if you use appropriate amount of moisturizer, it can take as high as 250 gram and above amount of moisture required per week. So it's quite an amount of moisture that's required. More importantly, moisturizer has to be used within 3 minutes after you have taken a bath or you wet your skins. So putting moisturizer, that's why I say always to my patients, moisturizer are not moisturizer, they are moisture retainer. So you need to moist your skin fast and then use a moisturizer because applying in a dry skin is absolutely useless. However, there is an issue with India, certain part of India like Calcutta, where a lot of hot and humid weather is there, especially in the summer. If you use a lot of moisturizer all over the body, patients tend to have a lot of sweats, and actually it can aggravate your atopic dermatitis because you know in atopics they are also sensitive to their own sweat also. So in that case we can avoid using moisturizer in the daytime and maybe as Indrashish told, use a coconut oil. that can be done, or you can take a leaf out of Sandipanda's book and use moisturizer only on the hotspot areas where the patient has regular, inflammatory lesion. Those areas only use the moisturizer. Otherwise, you can avoid the daytime moisturizer. But most of our patients these days, in the evening and night, they stay in air condition. So evening moisturizer is absolutely required. So that's how you can adjust according to the lifestyle of the patients.
I'll come to Dr. Ram. Say a patient is coming from an extremely humid area, say Calcutta, and another patient is coming from a dry heat area, say Delhi. So the amount and frequency of application of moisturizer.
Yeah, I think frequency of application, usually I recommend 2 to 3 times a day. That is something which they should use at least once after bath. And then as per the need, at least twice a day. But then definitely if you're in a humid environment, you don't want to put that moisturizer again and again. Okay. Second thing is, what are you going to put? So you can put a thicker moisturizer in the drier areas, and you can put a thinner moisturizer in the sweat-induced areas. So you go for lotions. Actually, in the areas where you got hot and humid, where the humidity is high, you probably go for creams or slightly thicker creams when you have got a drier ones. So that is something you should make a difference.
Yes, so that is a very take-home point. The choice of moisturizer does not depend only on the ingredient or only on the science and commerce concept. It goes by, whether you are applying on the affected area and that application of moisturizer in the hot spot area as suggested by Abhishek.
Also in seasons. In Calcutta, also in a dry winter, we may choose a defined kind of moisturizer. In hot summer, we can choose a defined kind, like lotion-based moisturizers.
So we would like to take up more and more audience questions. Please come up with whatever questions you have. We have an expert panel. We come back to the same question again. Chronic urticaria is very common. Kiran sir has extensively discussed, but I would like sir to repeat again what are the must-do investigations in a child with chronic urticaria for our audience.
See, urticaria, more than talk, there are more questions. Everybody has their own experience. So we are happy to take your question. Anything which you find suitable, good, we can take it and further. So typically for chronic urticaria, CBC, CRP, ESR, and this thing, IG, anti-TPO is good. Obviously for obese child, you will look for other thing. For urine infection, if it's there, you find out. But typically these are the basic thing, and then according to symptoms you can add. As a pediatrician, you know how well patient has got symptoms, so you can track it. But this will give you a rough guideline whether you are treating an autoimmune child or an autoallergic child. It makes a lot of difference in future because your treatment is going to respond according to that. And please, people will insist that you do allergy test. IG itna zyada hai, so kisse, why it is allergy? So you say, you cannot say that it is allergy to environment does. It is inside your body, autoimmune or autoallergic. So that you have to be very clear because parents are after doing those variety of allergy tests where advertised come. So refrain from doing those tests, and unnecessary, they stop giving feed to the child, stop giving ground nuts and 100 things, and actually child go into malnutrition. So don't do blanket ban or stopping 100 things. Please do not do it in urticaria. It is bad. Child's growth is important, and disease can be controlled with medicines.
I'll come to Indrashish. Like you are working in a government OPD, so poor patients are coming. They come just for the free cetirizine sample. So those patients, what are the must-do investigations in your OPD? Like if we write those 5-6 investigations.
No, I think routine blood investigation and ESR and CRP is something I do in all patients. Okay. Because they also have a prognostic value. Okay. Like eosinopenia and basopenia actually affect the prognosis.
Okay, and about total IgE?
And total IgE is something I think I don't, like it has been a kind of evolution for me. Yeah. When I was just passing out in the medical college, I used to say don't do IG in any patient because it's useless. Yes. Then after just reading something, then I realized that okay, it's great because it's also
we have been taught previously that IgE does not have any diagnostic or prognostic
value. So when I was
now the concept is changing.
Yes, so then I started saying that okay, it is in the basic investigation, that's in the guideline. But now what I realize is this IG is only important if you are planning to use omalizumab, because unless you are planning to use omalizumab, this total IG doesn't have much value because it will only help you predict the therapeutic response with omalizumab.
Okay, so now Kiran sir is eager to.
This is what because you asked that in a government setup. So
no, I am very happy if the panelists differ in opinion. Saying yes to everything does not make the panel very interesting. Yes, Kiran sir.
I can always do IgE say कि तुम्हारे खून में allergy है.
Okay.
moment I say तुम्हारे खून में allergy, he knows that there is something defect in my blood. So I should not worry much about eating. So that helps it. Obviously, it is a costly test, but you don't have to repeat it. It is once in lifetime. You do it once and wait. Do not do it again and again. So I know it is a costly, but it gives a lot of clearance to the family. कि तुम्हारे खून में दुश्मन है, तुम्हारे खून में allergy. He understands कि भाई the problem is in my blood, so I have to take medicine.
Abhishek, suppose a patient comes to you for the first visit. He presents to you a report of IgE 5000.
So we need to counsel the patient. See, there are basically two groups of allergies, and if your IgE is high, this is required to prognosticate the patient, not for treating the patient. So just tell that to the patient clearly that if your IgE is high, these are autoallergic type of chronic spontaneous urticaria. All your anti-allergic treatments seems to be working better in this group, and your amount of medicine has to be taken, and what is the duration of your disease will be lesser. So this is actually better, good prognostic indicator for the patient. So if it's not only about omalizumab, your antihistamines also work better if your IgE is higher than IgE is too low. So it's actually good prognostic marker. Let the patient reassure that you have just an allergy. It's nothing due something, autoimmune or something like that, which will going to drag for a long period of time. So yes, IgE should be done, but with a pinch of salt that just if you have a high IgE, the patient should not panic. And if you have a too high IgE, just rule out any other atopic dermatitis marker.
Yes. Thank you, Abhishek, for beautifully summing up. So the message is we are not treating the blood reports, we are treating the patients. So IgE is useless. That was the concept maybe 5 to 6 years back. Right now, that concept has been ruled out. Yes, sir. Please introduce yourself with your good name and place where you are coming from.
I'm Dr. Rishikesh Belsare. I am coming from Nagpur. I just wanted to ask Dr. Godse sir regarding the long-term use of Montelukast levocetirizine combinations, which are currently being prescribed left and right for papillary urticarias as well as chronic urticarias and acute urticarias, and considering the view like the role of leukotriene inhibitors, the side effects of leukotriene inhibitors, like the neuropsychiatric side effects. So I just wanted you to highlight on these issues.
So Montelukast was there in our guidelines 8 years back. Montelukast you use in urticaria only in 2 indications. One, if you have got respiratory allergy with urticaria, you give it. Or those who have got NSAID induced urticaria, there Montelukast work. Otherwise, routinely we don't advise to use Montelukast long term, and obviously the suicidal tendencies and long term side effects are being mentioned. So typically use only for these 2 indications, and typically not more than few to several months. That is what you will advise. So routinely no. So don't use this combination. Once you use a combination, then you can't updose levocetirizine. Use it separately. If at all you want to give Montelukast, give syrup of levocetirizine plain, so that you have a facility to updose it to 1, 2, 3, whatever you want to, or Bilashin, whatever it is. So always combo, let you dictate what you want to give, and not your pharma should dictate how you should give. So that's why this combination should not be used routinely for urticaria. It may be useful for rhinitis, but not for urticaria.
Just a couple of points I need to mention about the Montelukast. See, studies has proved 2 times elevation of levocetirizine is better working in chronic spontaneous urticaria than Montelukast plus levocetirizine. So no need to add a Montelukast and you just keep twice of levocetirizine. And then Montelukast cannot be updosed as I said. Third, if you continuously use Montelukast, like we use levocetirizine or any other antihistamine, which is quite safe, but for Montelukast, there's a theoretical risk of structural disease. So we need to be careful with using Montelukast. If you want to use it separately, and up to 3 months is preferable. After that, you should continue only with the antihistamines.
Can I make a comment, Anupam?
Of course, sir.
Thank you. I wanted this very important statement coming from the dais, particularly from Kiran, and Abhishek also very nicely added to that there is a tendency, I fully agree with Dr. Rishikesh. Actually, I stood up there just to ask the same question. Then I found that this had already been asked. Then that's why I came here. But I want to add further that yes, we see amongst our pediatrician colleagues a tendency of combining levocetirizine and Montelukast instead of just levocetirizine in chronic urticaria. So there is no role of Montelukast in urticaria. It is not US FDA approved indication. Forget about US FDA. One of the adverse effects of Montelukast out of 6 adverse effects, 5 or 6, is Stevens-Johnson syndrome and TEN. So I think one should be very careful because there is a lot of chances of litigations. If you write Montelukast, you won't be able to justify it in the court of law why you have written Montelukast when it is known from the literature that it has got hardly any role in urticaria except the drug-induced urticaria which Kiran mentioned.
Thank you, sir. We have Dr. Shamanto Borua from Assam Medical College, Dibrugarh. Sorry, I introduced you myself.
Thank you, Anupam. This is in reference to what Dr. Indrashish mentioned regarding serum IG, that it is important, it is probably a guide to the efficacy of omalizumab, right? Is the reverse true for cyclosporin? That is, lower levels of serum IG, do you find clinically correlates with more efficacy when you give cyclosporin? And why does it happen?
Good. So my lecture has made an impact. Yes, IG does give you
I was not
idea.
there. I'm sorry if you had mentioned that. I was not there probably during your talk.
So still you understood it. That's still better. No, just a fun part. See, typically IG, 5 years back, we also said, our guidelines say don't do it. Now we say do it because it gives us a clue. But let me tell you that Asians, like Indians, have always got persistent high IG level compared to the Europeans and Americans because of constant allergen exposure what we get in the cities. So our IG low is 100 and 200 is a low IG. Please remember, whereas low IG in Europe is 40, 30, 60. So a lower IG level is not just less than 100, 150, even 100, 200 is a lower IG. It should, because of constant allergen exposure. High IG, omalizumab will definitely work better in this patient. Low IG, cyclosporin will work better because it's an autoimmune nature. So typically your second line statement you decide by your IG level. So that's why it is important and it gives us a clue. And low IG and positive anti-TPO is 100% it's autoimmune nature. So here your cyclosporin should be a drug of choice after updosing.
1 point. Just 1 point to add. Yes, this is a common sense stuff. Your autoimmune things, which is 20% of your total chronic spontaneous urticaria, which is a typically high anti-TPO and low IgE, should cyclosporin be a group of treatment of choice from the day one? Actually, these are the group which has been told as a delayed responder to omalizumab. So, however, I must say, at this moment, we do not have enough data to actually say this is our gut feelings. And I told that in the Galen meeting also in Germany, and they said at this moment, we do not have enough data. So, at this moment, omalizumab still remains the treatment of choice as a third line of treatment. However, in case of India, where we can little bit go here and there without thinking too much about, guidelines and FDA approach, I think all those group of patients starting with a cyclosporin is a better option than an expensive omalizumab.
Yeah, Dr. Dinesh.
One point about Montelukast. Recently I read it somewhere that long-term Montelukast uses may lead to mental changes,
including suicidal tendencies.
Suicidal ideation.
Now there's a black box warning
mental problems, depression.
Yeah. So I wanted to ask you something, that what is the role of H2 receptor antagonists like ranitidine in chronic urticaria? That's one. And secondly, since morning we've been talking about chronic urticaria, we wanted to know something of acute also because that's more common. And the food and all you said it's not used in chronic, but in acute probably, these tree nuts and mushroom, seafood should be important.
So ranitidine coming to the one, well, H2 again, our 8-year-old guidelines had H2, like ranitidine as a second line therapy. Well, I do believe that H2 blocker do work because 10% of H2 receptors are in the skin apart from in the stomach. So those patients, it is worthwhile adding ranitidine or famotidine. Those who are not responding to updose of 4 tablets, you can try using it. It is no harm and they are safe. This thing. Coming to acute urticaria, well, acute urticaria is obviously you are the best just to find it out. So here the triggers most of the time is food, infection and drug. I think Abhishek you can.
So basically, one thing Sir has always mentioned that in Indian scenario where omalizumab and cyclosporin are both expensive for many of our patients, so you can go 7 drugs, that's our strategy, that 4 tablets of antihistamines, like whatever combination you want to give, twice daily H1 blocker like ranitidine, whatever dose is, H2 blocker like ranitidine or whatever drugs you want to see, and 1 Montelukast. If you cannot go to the other treatments, then in Indian scenario we can do these jugars so that you can go up to these tablets, which are the 7 tablets, and usually keep it safe and effective in certain patients of ours. Coming back to the acute urticaria, is the patients mostly have a very short duration of attack within the six weeks. So normal antihistamine standard dose is usually responsive to the patient. It's usually scary for the patient, but as a treating physicians, we know that this episode will go down. You can take a brief history. Usually the patient have a viral exanthem before or something like that. You can find some dental caries or some other infections, or the people may have certain foods. Now the food is more often food additives. It's not always the food, it's additive. The coloring agent, suppose the patient has taken a kulfi or something where there are a lot of, pink colors materials, there are yellow color materials, there are orange color materials, all these food color or the additive, the tin food, canned food, these are the things are much more commonly the inciting agent than food itself. And also, of course, if the patient has gone to a Chinese restaurant, like a lot of our patients go to this and added Ajinomoto or monosodium glutamate, those things are common offender than actually the food per se. True food allergies are found less than 2% of total patient of urticaria. So food is often overblamed. If there's a really food history the patient is giving, then rather than doing any test, you suggest a food challenge diary. Ask the patient to mention a diary and write whatever the patient is taking every day. And if there are episodes happening with the same food multiple times, then yes, then only you can think about a true food allergy. Otherwise, usually these are patients' own parents' own perspective than actually the disease.
Yeah, a chocolate question for the pediatrician colleagues. Yes, I'll come to you. 1 minute. Chocolate question for the audience. Name one serum biomarker which helps in assessing disease activity and severity. Reduction in count of something. Pediatrician colleagues. Yeah. Your good name and place, please.
Would not follow you. Low basophil count.
Yes. I want to know your name and place where you are coming from.
Dr. Gautam Sadhukan from Calcutta.
Yeah. Thank you. A chocolate for Dr. Gautam Sadhukan.
Okay, can I just add one thing to what has already been said?
For the chocolate?
No.
Okay.
To the food, what I suggest or I do nowadays is that, yes, chocolate can cause that. Usually these reactions, as it has been rightly said, they usually occur.
Okay, this question is also for you only.
It occurs
because I'll quote your article after this.
Okay, so they occur within 30 minutes to 1 hour. So that is the actual timeline, very important timeline, because all of these are immediate type hypersensitivity reactions. We all know about them. So if we are suspecting, so we can always tell patients that whatever food the child is having, whether these reactions develop within 1 hour, maximum of 1 hour, because they will usually develop within 30 minutes. Then you can say that if you see that any food you are giving, that as Abhishek Das said, that if the child is developing these reactions within 30 minutes to 1 hour, you just write that food down and maintain a food diary, which is of course very effective. So this is, I think, one way where we can easily screen out this lot of things. That you just ask the timing, because most of the time patients say that I had something in lunch, my reactions developed the next morning. I had something in dinner, reactions developed next day.
1 hour is the cutoff.
Yes, 1 hour is the cutoff.
Okay, I'll come to Dr. Raghubir. Before that, another chocolate question. What is the minimum duration for which the dietary elimination challenge should be conducted before we declare that the patient is, say, sensitive to this food item or not? For how many days the dietary elimination should be done? 1 week, 2 week, 3 week, 4 week for the pediatrician colleagues? Yeah? 3 weeks. Your good name?
Dr. Gopal Pandey.
From?
Malda.
Okay. Chocolate for Dr. Gopal Pandey, please. And claps also. Yes, ma'am.
Yeah, I just wanted to ask that during an urticaria, whether it is acute or chronic, there's a lot of itching involved. So what is the correct lotion that we can use? And as a pediatrician now, we are seeing a lot of urticaria and it's going on for 2 weeks and 3 weeks. When is the time? I mean, they keep coming and saying, the urticaria is not gone and it's interfering in school performance, etc. When is the time that we should understand now it's that time to hand over to the dermatologist? Because we panic a lot because they bug us a lot.
Yes. So this question will directly go to Kiran, sir. When should the pediatrician refer the patient to a
Very
dermatologist?
Please, I don't expect that you to refer this to a dermatologist immediately. You go up to updosing, you can try. Don't be in a hurry. You can, in fact, see patients are more attached to you than me because most of the child, they know the pediatrician doctor very well. So typically, when patient is well controlled with say antihistaminic, say 5 ml of 4 ml of bilastine, is well okay. So don't be in a hurry to reduce it. Tell you to take it for 1 month or 2 months and then say now you take it 2.5, half of this and another 1 month and then try to reduce it. So in spite of giving say 2 different antihistaminics in full dose, still patient is not responding and you are not keen to start either cyclosporine or romalizumab, that's the time. So up to 4-fold updosing a pediatrician can do, and most of the children are very well attached to pediatricians, so they listen to you better than us because we are there just for 5 to 10 minutes with him. So obviously up to 4 updosing, you have a right to keep with you, continue, and then you say that look, it's not responding, we'll take an opinion of dermatology. So don't be in a hurry to send it to a dermatologist. You try standard dosing and updosing.
We have one more doctor in the audience here. Could you please introduce yourself first?
Lotion. Yeah.
One part of the question was not answered. Madam, typically it's the oral antihistamine which gives better relief than anything topical. You may give certain calamine lotions, that is fine, but otherwise it's the high dose of good quality antihistamine that will give better relief to the itch than something applied. However, I may say there are certain differences in certain situations. Like a lot of people have atopic background and also have urticaria. Now, atopy itself causing itching, and that leads to more dermographism and urticaria. In this patient, emollient can be a good additive or standard treatment of atopic dermatitis you can also do. This is patient, and on sometimes delayed pressure urticaria happens where there is some role of topical steroids. Other than that, topical treatment doesn't have too much of role in the treatment of urticaria.
Another thing, when we are doing the investigations for urticaria, like supposing the child is going on for 2 weeks, then sometimes we add vitamin D levels and it comes very low. Is it a coincidental finding, very low vitamin D level in a persistent urticaria for more than 2 weeks?
Ma'am, we do not have any data till now that to suggest that vitamin D3 level has certain role in the urticaria. However, there are certain suggestions that low vitamin D may be making the disease more worse prognosis. Currently, we are doing a study on vitamin D3 level, not in the pediatric age, but in the adults, and adding vitamin D3 on a treatment. A little bit, off the label, I'm talking about that we are getting better response with antihistamine plus vitamin D3 in this subgroup than only with antihistamine. However, the entire analysis is not done, so it's not published, so I cannot comment on that.
I'll come to Dr. Bornali. Very briefly, I think this was discussed by Kiran sir, but still a very strong message should go from the panel. When should we consider prescribing oral steroids in chronic urticaria?
Oral steroids, as a rule, we don't use in chronic urticaria, but there are certain situations when it can be used. When a patient comes with an acute flare of urticaria, there might be associated respiratory distress, or there might be angioedema. Then there might be a time that the patient is on very high dose of the optimum dose of steroids at 4 times. Updosing is there. We are planning for cyclosporine or omalizumab, but maybe the patient is not able to come to a decision that is ready for that, or we are taking some time to do the baseline investigations. That might be a time. And these are basically the main situations, mostly to control the acute flare. On a patient of chronic urticaria coming with acute flare and some systemic complaints.
Okay. I'll come to Kiran sir. Like you mentioned that you do not prescribe sedating antihistamines at all. Any situation where you will prefer sedating antihistamine over non-sedating antihistamine in a patient of chronic urticaria? Because you mentioned that, that's why.
Yeah, so our guidelines clearly state do not give older antihistamines routinely in the patients, but especially in an atopic child or somebody that got atopic and urticaria lesion and somebody child is not able to sleep, you can give hydroxyzine for a few days to this thing, but don't give it as a routinely. See, 10-20 years back, Malcolm Greaves came and said that you give fexofenadine in the morning and hydroxyzine in the night, and whole India started writing it. That was around 20 years back, but now the things have changed. Now we know the long-term effect and side effect. Or even giving hydroxyzine for a child for long-term has got many problems, including learning disability and growth retardation. So typically, not more than 5 to 10 days or 15 days, you give it for urticaria. Well, atopic, yes, you do advise.
Okay, yeah. Good morning, Dr. Abhishek Jadhav from Mumbai. I would like to ask panel about the, Dr. Abhishek mentioned about the additives in the food, but I would like to take it on the other side of the spectrum, the additives mostly in the preservatives, in moisturizers, cleansers, and their role in atopy or, even on the urticaria. What does the panel have view on that?
That's an interesting question. Of course, there has been some role of, all these preservatives and additives. So we need to reduce the amount of additives in all moisturizers. So that's why I say no fragrances, no color, nothing like that. And there's a question of paraben, because that is the commonly added, preservative in all moisturizers. And most popular brand has a lot of parabens, 3 types of paraben, in fact. However,
Abhishek, I would like to interrupt you. Just 15 minutes back, we were telling that moisturizers with good smell. And now we are telling that moisturizers with fragrances should be avoided.
So the thing is that paraben hypersensitivity is often overemphasized. And the amount of patient developing contact dermatitis to paraben is abysmally low. That's why in 2019, and you check in Google, US has told every year they have this one allergen per year. In 2019, they have made paraben non-allergen of the year.
Yes.
That's why you need to be sure that this is possibly it's not causing any aggravation to the atopic or contact dermatitis.
So paraben causing the allergy is probably a hype. Right.
Yeah. See, additives in that, whatever you apply, they are less likely to cause urticaria. They are more likely to cause contact dermatitis or worsening of atopic dermatitis. So for urticaria, they could be safe because skin is intact. And the skin is not intact in atopic and other thing. So that's you have to worry about.
Yeah. So Dr. Raghubir, you wanted to say something?
Actually, practically it's an overhype. Fragrance free, this free, that free. So as Abhishek has rightly pointed out, the incidence of contact dermatitis to those agents are very low. So I don't think practically it has a lot of problems or issues.
Kiran, this question may be answered by you or your disciple Abhishek. Regarding this so-called the allergen of the year or non-allergen of the year, I was aware of the allergen of the year. I was not aware of the new category, non-allergen of the year. So we always knew that gold does not contact dermatitis, but in 2014 it was stamped as the allergen of the year. So you were surprised. So now you are telling from our growing up years, we always knew that paraben is a culprit. So now it is stamped that paraben is the non-allergen of the year. So what is your take on this? Because this is an evolving science, and every 2 years or 3 years, our idea based on the new evidence is coming up on new publications. So where exactly do we stand?
Yeah, I always say medicine is an evolving science. Every day something new is happening, and it has got relevance in our day-to-day living. So that's why you have to abreast with the knowledge, and all these kind of conferences are important to understand what is, because I alone cannot learn whole of dermatology, a pediatrician cannot expect. So this keeps on changing environment, you must know. So obviously the newer allergens, as far we have just discussed about, these are going to change our perspective, how you treat disease in the future. So I think they are important.
Yeah, Dr. B.K. Nath. Yeah.
Just think about, I wanted to add that, all these children who are having atopic dermatitis also tend to have allergic rhinitis and asthma. So if you have a strong perfume, it tends to increase that. So we should not idly be having these perfumes for allergic children like atopic dermatitis.
I was just collecting my data on patch testing, and I had 370 patients total data of patch testing, and I found out not a single patient ever came positive for paraben. Just to emphasize that contact dermatitis to paraben must be very, very low.
Yeah, Dr. B.K. Nath.
My question for Dr. Godse, sir. Sir, sometimes it is seen that in most of the chronic urticaria patients, they are responding well to second generation antihistaminic, but as soon as we try to stop it, there again relapse is seen. So how long, sir, you can give safely second generation antihistaminic to the patients? How long?
It is like Chakravyuh, Abhimanyu knows how to go inside, but he doesn't know how to come out. The same thing is there for all of us, for JAK inhibitor, for anything. So how to come out? But for urticaria,
we know when to come down. So one important thing, don't be in a hurry. If patient is well controlled, we say 1 bilastine and 1 levocetirizine. Don't be in a hurry. After 20 days, stop it. No. 2 to 3 months, you give it on same dose. After 2 months, you try to reduce 1. After 2 months, you try to reduce 1. So every 2 months, you can reduce. Longest, all the antihistaminics safely can give a long time. Biggest studies for levocetirizine, 3 to 5 years. It takes study. Bilastine up to 1 year, you can safely give. I mean, these are studies. Obviously, we know that the metabolism-wise, they are safe. So typically, most of the antihistamines can be given safe lifetime. Same like antihypertensives or anti-diabetic drugs. So do not worry about. But don't be in a hurry. Typically, we call patient every 20 days. Patient said, I am fine. So, okay, reduce this. Moment you reduce, he start getting it. So don't be in a hurry to reduce. You are not giving any harm. So give it for 2 months, then make it reduce, then another 2 months. So typically, it should go for 1 year, So your one patient is your fixed deposit with interest every 2 months.
Yeah. We are running short of time. So this question has been partly discussed by Ram sir. Still, if you could repeat for the pediatrician colleagues. Or should I say all cases of cutaneous adverse drug reactions should be referred to a dermatologist? No.
I think simple mobile-form rashes with the child is systemically well. If you've got an FDE or single FDE and they're confident of the drug which is to be removed, I think there are minor rashes which can be taken care of. But if you've got a diagnosis in doubt, that is one thing you take care of the attending dermatologist. If you have got a rash which is associated with widespread erythema, pustules, denuded skin, dots which are targetoid in appearance, if you've got skin with mucosal involvement and a sick child, I think these are the ones where you definitely get a dermatologist opinion of the rash that is developing. And then fever and lymphadenopathy with facial edema with a rash, again, that is something which is a red flag.
Correct. So Indrashish, we are very short of time. This patient comes to you in a busy OPD. Very briefly, how to approach?
I think that this picture, this kind of situation has been extensively dealt with in the presentation. Like we have to rule out viral exanthem and drug-induced.
The common clinical differences between viral exanthema and drug rash.
It has been like the prodromal symptoms, like fever and this kind of things are more common in viral infections. Take the drug history, which is very common. The evolution of the rash, whether it is starting from centripetally or centrifugally. You see the palms and soles. Pruritus is more common in drug eruptions. Palm soles involvement is more in the drug eruption. Mucosal involvement is more important or more common in the viral infection group. Of course, they can also happen in the drug cases, but they are more common in the viral infection group. Fever and other prodromal signs, I think these are some of the common things which we need. And facial edema, very important, very pointer of drug-induced reaction, facial edema. So I think these are some of the things how we approach to that.
Ram sir, I would again come back to you very briefly. Like we are already out of time.
Yeah, I think if you've got a child who has got a hemorrhagic crusting, you're thinking in terms of an SJ syndrome.
Yes.
Whether it's a mucosal SJS or you got the skin lesion, I think skin lesions are there as well. Yeah. So think of an SJ syndrome, think of drug. And I think again draw a timeline, see which drug actually caused it. That is really important. And I think it needs to be go down the lane of an SJ syndrome. This one is complete denudation of the skin, so it's a toxic epidermal necrolysis that you're dealing with. And these children need inpatient, almost kind of a burn unit environment where they have barrier nursing. And then a dermatologist needs to be involved in such a case.
So I would like to wind up the panel by saying that it's not that the pediatricians and dermatologists, they are sitting in two separate watertight compartments. Both the specialties need to accept their limitations. Like a dermatologist is not well versed to handle the systemic facet of cutaneous diseases, similarly pediatricians are not well versed to handle the cutaneous diseases. So the important message is like, we should not shy away from referring patients whenever in doubt. We should not shy away from admitting patients whenever we are suspecting any severe cutaneous drug reaction, as Ram sir mentioned. So far as urticaria is concerned, Kiran sir mentioned that urticaria cannot be treated. We can just control the flares. We can just control or rather slow down the progression of the disease towards more serious complications.
Can it be treated?
Sorry. Yeah, it cannot be cured. It can be treated. We can control the disease. We cannot cure the disease. So far as choice of antihistamine is concerned, of course, second generation antihistamines are the drugs of choice. Sedative antihistamines, no. Montelukast, absolutely no, unless the patient is having NSAID-induced allergy or the patient is having respiratory allergy. Oral steroids, no, maximum for 5 to 10 days if there is an acute flare. Coming to investigation, CBC, CRP, definitely yes. Total IgE, 5 to 7 years back, we had an idea that it is useless, but right now, no. It definitely it has a prognostic value whenever we are thinking of the long-term course of the disease, whenever we are thinking of prescribing omalizumab or cyclosporin or something like that. So far as non-antihistamines are concerned, in pediatric age group, we do not have much data, so rather not to be too much adventurous. Cyclosporin, yes. Other drugs, probably no. Coming to, and if the patient can afford, yes, we can go for IgG anti-TPO as well. So far as CADRs are concerned, probably maculopapular drug rash is the commonest thing which we encounter in our OPDs. If we are coming across facial edema, if you are coming across mucosal involvement, if you are coming across widespread erythema, always think of referring the patient to a dermat, because things may take up medico-legal turns if a proper referral is not done. So let's accept our limitations and work for the betterment of our patients. Thank you, my esteemed panelists and the organizers, for this opportunity. Thank you.